Okay, good afternoon, everyone. It is now 2 o'clock. Thank you so much for joining us today. Again, we're the Global Partnership for Telehealth and are thankful for you to join us today for a presentation from Northside Hospital concussion specialists who are going to discuss their telehealth program for concussion care and treatment in children. A couple housekeeping items. Again, your mics are muted, so if you have any questions, please type them in the questions and answers box or in the chat. The meeting will be facilitated by myself and Boyd Mark. And with that, I will go ahead and turn it over to Boyd for introductions. Thank you all again.
Thank you, Salima. The Global Partnership for Telehealth is so pleased to host this very important topic and these specialists who are with us today from the Northside Hospital Orthopedic Institute, Dr. Amy Fader and Dr. Dan Cherrick. They're both fellowship trained and licensed neuropsychologists who focus on the assessment and treatment of concussion in athletes and non-athletes. Dr. Fader earned her doctoral degree in clinical psychology with a focus in neuropsychology from Central Michigan University. She works with multidisciplinary teams to provide comprehensive evaluations for patients across the lifespan while specializing in pediatric and adolescent populations. And Dr. Dan Cherrick received his undergraduate degree in psychology from the University of Akron and his doctoral degree in clinical psychology from the University of Toledo. His expertise is in performing comprehensive neuropsychological evaluations, and in the case of head injury, diagnosing the extent of the injury and tracking treatment process. They have a fantastic program that is available to your school, to your clinic, to your practice. And with that, I'm going to turn it over to Dr. Cherrick and Dr. Fader to tell you more about it.
Yeah, so we very much appreciate the introduction and everyone taking some time to be with us here today. I'm excited for the opportunity to talk with you guys. So both myself and Dr. Fader are going to kind of break the talk up. We're going to start with Dr. Fader talking a little bit about how concussion has changed, which it has dramatically in the past 10 and even 5 years. We're seeing rapid progress in how we manage this injury, transitioning from historically a much more conservative and passive approach to one that's much more active, both in terms of treatment recommendations, but also how we approach getting people back into things like school and exercise. So we'll have a conversation around that and how that literature has changed. And then we'll transition into talking more specifically about how we target treatment much more than we had in the past, as opposed to kind of a one-size-fits-all approach to the injury, which we really took in the past. We're now much more specific in terms of recommendations based on different types of clinical presentations. Then we'll kind of wrap that up with talking about how we're also able to provide that more remotely through telehealth services as well. So with that, I'll turn it over to Dr. Fader and let her kind of get us started.
Thanks. Okay, is that showing up for everyone all right?
That is perfect.
Excellent. Okay. So again, yeah, Dr. Cherrick already discussed these objectives. So I'm going to kind of lead us in with some of these advances in concussion evaluation more specifically. And some of the clinical research that we've done, we've confirmed a lot of the things that we maybe anecdotally thought we knew. One of those being early targeted intervention absolutely matters. So we know that early specialty care is associated with a shorter recovery time. We've looked at this in a couple of ways. We've looked at this more in an adolescent population and in a pediatric population, and found that those evaluated within a specialty setting within 1 week of injury after a concussion recovered in a mean of 20 days faster than those athletes seen 2 to 3 weeks post-injury. So we know that getting on top of this, really getting appropriate management on the front end, really is effective. Furthermore, we know that concussion it's not the same for everyone. Each patient presents with not only different pre-existing risk factors, but also different characteristics in how they interpret an injury and different injury biomechanics, how they sustain the injury. It is complex. It affects each individual differently in the symptoms that they present with. And as such, a uniform cookbook approach just isn't that effective. In other ways that concussion treatment has changed, before we had more of that passive, maybe strict rest cocooning kind of on the far end. More in the intermediate is more of this, just wait and see. Hey, let's check in a week, see how it looks, check in another week, see how it looks. And more avoidance based. Let's avoid symptoms until you feel better. Modern approaches to treatment, much more active, much more targeted to each profile of symptoms, and exposure based, meaning, hey, let's try and expose to stimuli that are provocative. Let's see how we can tolerate that to find our threshold. And let's work with using breaks and kind of management from that end. And we know that this more active approach facilitates faster recovery through some good empirical research. When we look back at that more strict rest-based approach, we know that this had been a cornerstone previously. And the rationale kind of makes sense from the initial view is, it's kind of based on animal models. Rest, it's good when we're sick. It's good for lots of things. But our research doesn't really support that in humic subjects, and that it might actually be detrimental instead of helpful, particularly if we're following a strict rest-based approach for a sustained period of time. So when we're looking at a randomized control trial of rest versus usual care, the individuals who are recommended a strict rest-based approach, no school, work, physical activity for at least 5 days, versus those who were told to, okay, maybe rest a day, maybe 2, but then progressively get back to activity using a symptom management approach. Those in the strict rest-based group had higher symptom scores throughout the course of the initial recovery. So we know that this is associated with higher symptom burden than if you're actually doing a little bit more, having that exposure. Your symptom burden is actually lower as you're getting desensitized to that stimuli. In addition, we know that there, especially with our pediatric and adolescent populations, mood can really be affected by this. One, we're creatures of routine. Kids are creatures of routine. We lose that routine. We develop anxiety. We develop kind of unsure of what's going to come next. There's isolation, missing out on seeing peers, not being told that they can't look at their phone and text their peers even. Missed school and sport, losing their starting spot, missing classes, and the stress associated with that is substantial. We know that if you're left in a dark room, not much to think about, individuals often develop a lot of this kind of hypervigilance or this attentional bias towards their symptoms. They're left to think, oh, all I've got to think about is my headache here, so I'm really fixated on it. And discharge instructions for rest actually are equated with more symptoms, and it may be because of this kind of contextual framing effect. People are expecting that they will be symptomatic, so they're almost looking for it. They're expecting to frame their recovery in that way. On the other hand, more active treatment includes multiple components, not only return to normal activity, like doing your daily chores, everything like that, but early progression back to exercise. Moderated exercise is actually associated with faster recovery and lower symptom burden. It also reduces the risk of all those things we just talked about. The negative mood effects, isolation, for our athletes, deconditioning. They spent a whole lot of time getting conditioned for a sport. Ideally, we don't want to remove them for weeks on end if we don't have to and have them get deconditioned. And we also know that staying physically active in a safe way helps reduce the risk of sustaining other injuries upon their return. So the figures below is another randomized control trial. This is looking at those who were assigned to either a stretching group or a group of aerobic exercise, and then looking at how many of them had recovered and looking at their symptom report over time. As we look at that, we see that those in the aerobic exercise group are getting to an asymptomatic status and getting cleared sooner than those in the strictly rest group, or in the strictly stretching group, I apologize. Furthermore, their symptom burden, even before they are getting cleared, is lower in this aerobic exercise group than the stretching group. In addition to physical activity, the more active approach applies to return to learn and return to school as well. We really recommend having that brief, if a rest period, a brief rest period, followed by a return to the school environment with tailored accommodations to support that return, with the goal of reducing the academic challenges associated with missing a lot of time and the stress coming with that. And what it would look like, this might look like maybe a couple days of half days, then getting back to more full days pretty quickly, having that support network around them. We found that communication between providers, parents, and school personnel is crucial to address what can be kind of a hidden injury. Teachers can't always see this. We're fortunate to have an education coordinator in clinic who really helps facilitate this communication so that everyone's on the same page as somebody is coming back from an injury. So that's looking more at, hey, how have we changed our mindset about how to manage this injury? As we look more into the evaluation component, we're looking at different clusters of symptoms. We have more of our physical symptoms, your hallmark headache, light noise sensitivity, dizziness. We might have blurred or double vision imbalance in there as well. We're looking more at cognitive problems, attention, concentration, having some trouble remembering information, learning new information, and then this sensation of fogginess, this out of it, step behind. Concussion may also affect, in even more hidden ways, the psychological perspective. Somebody showing more anxiety, more emotionality. They're more irritable, they're frustrated. And sleep symptoms. Maybe they're sleeping more than usual, but we can also see that they're having a lot of sleep disruption, and they're waking still feeling fatigued, feeling drowsy through the day. Concussion evaluation is more than just an interview or a symptom report at this point. We know that multiple domains are affected by concussion, so we've really adjusted our evaluation to account for those different domains. It includes cognitive testing and screening, mood measures. It includes vestibular and ocular motor screening as well. So really trying to get the whole picture of how this injury is affecting an individual. This comprehensive evaluation also accounts for their medical history. We know that there are certain risk factors for more of a complicated recovery after concussion. This might include things like migraine history, history of motion sickness, ADHD, anxiety, or depression. Doing this in a multimodal way allows us to be more objective and less reliant on patient report. Gets a little different picture. And not only that, allows us to target the recommendations to each of these different domains that we are assessing. When we're looking at the cognitive testing component of our evaluation, we in clinic use the impact testing. It's really supported by an extensive body of research on the reliability, the validity, the clinical utility of this testing. It assesses a few different domains. Memory, broken down into verbal memory, visual memory, and then more the speed of processing, visual motor speed and reaction time. We also account for total symptom score and an impulse control composite with this. We really like to do this, helps us tailor our academic accommodations as well and give a good picture of how this has affected individuals in that way. Many individuals have baseline testing for this if they've done that through an academic program or a sport program. But if not, we have normative data that compares an individual to their peer group. And that ranges all the way from ages 12 through 80. Even ages 10 through 11, we have some additional research to support normative groups there. So we can really not only look at the individual, but look at them compared to a larger group. The next piece is looking at vestibular and ocular motor screening. So we know that concussion can affect our visual processing. It may look like blurred vision or double vision, and we can actually account for this through looking at various parts of our exam. We're looking at smooth pursuits. We're looking at horizontal and vertical saccadic movement. We're looking at near point of convergence to see if vision is doubling with that. And then the second piece looks a little bit more at that vestibular functioning. Dr. Cherek's going to talk a little bit more about the treatment of this and what that looks like. But that's just an overview. As part of the brain helps us process movement, helps us keep our vision stable while we're moving, helps with balance. So we look at that through some various head movements to account for whether somebody is dizzy after an injury. It helps us tailor recommendations. So I'm going to hand it off to Dr. Cherek, talk a little bit more about the treatment component.
Yeah, and so I think a confusion we'll get sometimes from our parents or even sometimes providers who had been used to this more kind of rest-based approach to concussion is, okay, so you're telling us we have all these different tools now, there's additional testing measures we have. How do we use that to actually guide our recommendations? And I always let everyone know the first rule is still, if you're still dealing with symptoms, if you're still actively concussed, we're certainly keeping you out of any contact at that point in time. But from there, really every recommendation we're going to make around how do we activate you back to things like school? How do we work you back into things like exercise? Is going to be based on kind of this profile-based model that we're about to assess or we're about to talk through. And so by getting information like how does someone look on the impact test? How does someone look with vestibular and ocular motor testing? How do they present their symptoms? What do they describe to us? We're going to use that to figure out which of these 6 different subtypes of concussion. So what we have here is vestibular profile, ocular motor profile, cognitive fatigue difficulties, post-traumatic migraine or headache, cervicogenic issues, or anxiety and mood-related symptoms. And we're going to kind of go ahead and run through each of these separately as we go through here. And this slide is just kind of a general overview showing that based on each of these different profiles, you will have very specific targeted treatment recommendations. So what we're going to recommend to you to help potentially rehabilitate a system is going to be based on what specific problems do you present with. Similarly, I'd say your academic accommodations are going to differ depending what profile you present with. And so everything that we're going to recommend to you is going to be targeted based on which profile or profiles you fall into. So kind of moving into the first profile we'll discuss here, it's that vestibular system. So our vestibular profile, these are going to be our athletes who their vestibular system has been affected by their concussion. The primary symptoms or complaints you're going to hear from someone dealing with this difficulty is a lot of problems with dizziness or feeling like their balance has been affected by the injury. These are also the individuals who are going to complain that they find very busy environments bother them. So going into something like a grocery store where they're walking down aisles, there's a lot of visual feedback on both sides of them. People are walking past them. They'll find an environment like that to be bothersome. Or for our students, sometimes this will be that class change when they're in the hallway. There's a lot of people around them, a lot of noise that they have to filter through, or something like the cafeteria. So this is any environment where they have to process a lot of visual movement and motion is going to be a little bit challenging for them. And again, what's underlying that vestibular system is that network of inner ear canals, and then the brain processing that information about how we're physically moving with what we're visually seeing. And so in this case of concussion and people dealing with this difficulty, they're just not integrating that information as well as normal. There's 2 main reflexes that are really important for purposes of concussion and understanding this system. Classically, what we looked at is the vestibulospinal reflex, which is really important for postural stability. So the ability to kind of monitor where you're at in space and use that to maintain your balance. And some of our classic concussion testing that a lot of people are familiar with is balance testing. So having them stand in various positions and monitor how well they're able to maintain that position. And balance testing is still used very frequently. It's a very useful tool, especially early on in the injury. Very sensitive for the first 3 to 5 days, but it tends to become a little less sensitive as we get further out. It seems like that particular reflex bounces back fairly quickly. But what we're learning is the vestibulo-ocular reflex tends to potentially linger as having difficulties for a longer period of time. And that's where we've had to identify some different tools for measuring that. And so that vestibulo-ocular reflex, Dr. Fader kind of alluded to it, but it's very important for gaze stabilization. So if you're looking at a stationary target and moving your head, your eyeballs stay focused on the target you're looking at. In order for that to happen, as your head turns to the side, your vestibular system reads, how quickly did my head turn? How far did it turn? And there's a reflex that moves the eyes in the perfect opposite direction at the opposite speed to keep the retina focused where it needs to be focused. That reflex can get a little bit affected for people following concussion. When that occurs, that's something that we can rehabilitate. And so sometimes we will see people struggle with that difficulty, and that's where something like a course of vestibular rehab, either with a physical therapist or even potentially sending some home exercises, can be really helpful in working people through this specific area of difficulty. These individuals might have a little bit more difficulty initially getting back into exercise just because some of that dynamic movement can bother them, but oftentimes we can use that as part of the rehabilitation plan. So we can prescribe specific intensities or types of movements to kind of desensitize them as they work through it. So that's how we would address a vestibular issue. The next profile we'll talk about is more that ocular motor profile. So this is difficulties with the brain controlling that musculature around the eyes to perform coordinated eye movements. So some of the most common difficulties we'll see, convergence insufficiency is one of the more common. So this is the ability for the eyes to kind of converge or diverge on a target as it gets closer or further away. So these are the people who might deal with some intermittent double vision, for instance, or if they read for a long time, they find that their eyes are kind of fatiguing on them and maybe becoming blurry. We'll also see difficulty with accommodation, so the ability to kind of adjust the curvature of the lens. So people might feel like their eyes aren't kind of seeing as clearly as they normally would, or there might be a difference between the two eyes. We can see difficulty just controlling slow, smooth pursuits or even quick saccadic eye movements, and this might correspond with difficulties with things like reading. So this particular profile is one where academic accommodations become very important because obviously everything is very visual for people in the academic environment. Also, in the past, we would hear like, don't ever look at a computer screen if you have a concussion. Honestly, this is usually the group we have to be a little more stringent on recommendations around like sustained screen exposure. Not that it has to be completely outlawed, but you might just have to be much more proactive with breaks and use things like handouts, for instance, at school to kind of give their eyes a chance to take some breaks and get away from some of that. But this system too, this is one where if there's difficulties here, we can give some good targeted home rehabilitation exercises or a good course of targeted physical therapy to literally get the brain to be retrained to controlling these eye movements, getting those eyes moving smoothly in a coordinated fashion. And as that happens, we'll see people progressively improve. The next profile we'll touch on here is going to be our cognitive fatigue profile. So with cognitive fatigue, this is exactly what it sounds like. People who struggle with thinking related difficulties or sustained energy levels throughout the day. So cognitive difficulties are very common, particularly early in the injury. In fact, that's why we use things like cognitive testing, like impact, to really determine if an injury has occurred. And again, some people, this won't be the major area of deficit for them. And I always like to highlight that to people because if anyone tells you they're using something just like impact as their sole tool to diagnose concussion, that would be inaccurate. We want to just make sure we're incorporating that information alongside other clinical data, because again, some people may not have significant cognitive problems, while for other people that may be their main area of difficulty. But once we know if that's part of someone's presentation, again, we might be a little more conservative in getting them back to testing if that's the case, just so we don't have them fail a test, have their stress shoot through the roof, and that be a big difficulty. So we might give them a week before we work them back into that, but figure out what they look like from a cognitive standpoint, use that information to target their rehab. The good news is we really expect this system to naturally bounce back very well. In fact, that's usually one of our markers for when someone has recovered, is when those test scores look like they've gotten back to baseline or within normal limits. Similarly with fatigue, very common to see people early on. This injury is ultimately like a brain inefficiency problem and an energy problem. And so people tend to feel quite tired early on. One of the things I always like to set an expectation around and caution patients against early on, there can be this sort of tendency where you feel tired, and we'll see people start napping a ton with this injury. So we'll see people who are sleeping 3-4 hours at a clip during the day, but their main complaint is they're still tired because they try to go to sleep at night, they can't fall asleep, or they're having difficulty staying asleep. they wake tired the next day, they nap again, and we can see people really invert their sleep schedule that way. So I always try to recommend first 48, 72 hours, let your body be your guide on the fatigue piece. But from there, we really want to focus on getting back into that good, consistent nighttime sleep schedule, and try to preserve that as well as we can. So our next profile we're going to touch on is the post-traumatic migraine profile, or just post-traumatic headache. Now, it is the case that some of our patients will deal with true migraine symptoms following this injury. So they'll have oftentimes that one-sided headache. It'll be accompanied by that intense light and noise sensitivity, sometimes nausea, even vomiting. And in fact, your patients who deal with true migraine symptoms following the injury, that's often one of those predictors of someone who's going to take longer to recover from their injury. I will also note one of those risk factors we talked about, people who tend to have a pre-injury migraine history are more likely to experience migraine post-injury, and then also potentially take longer to recover. So it's always good to differentiate. Is it just that classic concussion headache, which is often more that kind of band of pressure tension headache type presentation, versus true migraine symptoms, which might give you some clues as to how these people are going to likely respond. Our most classic way for managing headaches, one thing is try to use your response to stimuli throughout the day, so your symptom response, to try to take breaks and minimize how much that headache spikes. It tends to be the case that if your symptoms just progressively worsen over the course of the day, you get to this point of no return, and it's really hard to rebound from that. So instead, what we usually recommend is, as your symptoms start to increase, take a break so you can bring those back down and keep them in the more mild to moderate range. And then some other just basic recommendations around good hydration strategies, good sleep patterns, dietary habits, stress management, all of that from a lifestyle standpoint can help to minimize the headaches. In some cases, particularly those post-traumatic migraine cases, if that lingers, sometimes medications can have an appropriate place in terms of managing the injury, but oftentimes we're successful in managing without needing to go down that path. Then the next profile we'll touch on is kind of that anxiety and mood related profile. This is anyone who's dealt with teens going through this injury. This is a tricky part of the injury to deal with. And some of that, again, was based on the way we managed it in the past, but some of it is, even if you try to keep people active, there is going to be some effect on day-to-day functioning because of this injury. Even if that's providing accommodations, but just needing to moderate things a little bit, it's still probably going to have some effect on school for a short period of time. But oftentimes your super high achieving AP student is going to really struggle with any interruption to school. And so knowing that and trying to manage that and set some appropriate expectations up front can be very helpful. This tends to affect, at least to some extent, sports activity, social activity. And again, trying to be very proactive in having discussions around that and setting those right expectations up front is really one of the reasons we suspect that starting early and getting into a specialty clinic where you can proactively work through some of those early hurdles and set them up with the right expectations and right protocol can really help to minimize some of the anxiety and mood related symptoms that we can see. But generally, this is something we're going to consider in every evaluation. To some extent, it's probably relevant to each person's case. And usually the more straightforward the case, the less anxiety and mood considerations you have to take into account. But this can definitely be one of those things, particularly in those cases that take a while for people to bounce back from. It's something you're typically going to have to manage proactively. The other thing I'll mention, we don't have a specific slide for this one, but the cervicogenic profile, the main reason I don't have a slide for it is I like to always make sure people know we're not talking concussion when we're talking cervicogenic issue, right? We're not at the brain level at that point. But I think it's really important for us to make sure it's managed, because we will have some of those cases where you've treated the concussion as well as you can, but if they're still dealing with a ton of neck related pain, for instance, that hasn't been addressed, hasn't been treated, and then you get that headache that radiates up through the back of the head. Well, do we have a headache because of ongoing concussion related problems? Is it more cervicogenic in nature? And so I think that always just harkens back to we're treating one injury here. We're talking about one injury here, concussion, but it's important to remember that occurs in the context of a whole person. And so just making sure we're touching on those different pieces that can potentially be relevant to getting them feeling better as a whole and potentially getting back to the things they want to get back to, like school and sports, for instance, is very important. And then we'll touch on a little bit here on our next slides. How can we sort of migrate this this type of evaluation to a more telehealth-based setting. And unfortunately, us, just like everyone else, a few years back, were forced to figure out a way to make this happen pretty quickly. The good news is a lot of the types of evaluation tools and types of evaluation that we do can be migrated to a sort of telehealth-based setting fairly well. A lot of our testing is computer based, and that can be extremely helpful because you actually have the ability. So for instance, Impact or a lot of the different tools that are out there provide you with options for, in a secure way, providing access to a single test for a single individual who can then take that test. You have access to that information in real time, so you can take a look at their results and kind of work through that. So we have very good means of getting some of the cognitive data that we use with the right creativity and assistance from kind of your admin within the hospital. We've been able to even work towards developing some of our more psychological assessment tools. So some of our symptom inventories and things like that, potentially have those navigated into a more of an electronic form that can kind of come in with some of our different like registration paperwork, for instance, so we can get some of that data on overall symptom burden, psychological inventories like anxiety, mood measures, things like that. And then some of our other testing, for instance, balance testing or vestibular oculomotor testing. You guys saw some of those pictures, but a lot of what you're deciding there and the decisions you're making is based on, is the patient reporting an increase in symptoms while they're doing that testing? Or what are you visually seeing in terms of how they perform that? So with a good camera and internet connection, you can really get a very good image if they get close up on how their eyes are moving as you're doing some of these different movements. When they're doing balance testing, are they able to maintain their posture appropriately? And so a lot of these tools can be fairly easily navigated into a telehealth setting so that you can do that evaluation, get that data you need to really determine what profile are we dealing with and what accommodations and recommendations do we need to target with that. But as you'll see, there's also potentially some limitations, and I think that's the case for everyone. We all understand, in a perfect world, you have someone sitting directly in an office with you just because you get that direct face-to-face feedback. But again, for the most part, these tools work pretty well. There are some challenges. One is, quality of internet connection. I think halfway through, I noticed my camera kind of froze up on us a little bit, it looked like. And that's something that, can certainly be a challenge when you're trying to get information from someone who's explaining things that are fairly complicated. How are you feeling about something? How have you done in terms of trying to get back into school? How are you coping with this injury? And if that gets interrupted and you're saying, wait, could you go back and say that again? That can be a challenge at times. So again, with a good quality internet connection, we can bypass a lot of that. One tricky piece for sure for us has been the ability to directly monitor things like cognitive testing. In a perfect world, you're able to kind of directly observe that the person who says they're taking the test is in fact taking the test. They're focused on the test, not looking at their cell phone while they're doing it. And they're putting in good effort, because depending on the situation, if someone is taking a baseline test, for instance, they could potentially be like, well, if I don't perform as well, I don't have to perform as well if I potentially get injured, so it's easier to get cleared. So you want to make sure they're really giving some good effort. And at the same time, you want to make sure they're not, writing down a word list or something like that. We have experimented with and we're working to develop better ways to kind of do this. One thing is really using parents as an ally to really explain, what does the testing environment need to look like? It should be quiet. There shouldn't be a TV on. These are the expectations around it, and using them as an ally to kind of help in fostering that environment. We've even worked with some of our like baseline testing protocols to include like monitor testing where they have to take it, where there's like a laptop with a webcam, and so we kind of present the instructions to them and everything watches. So there's creative ways to potentially work around this, but it's always a consideration. What is the testing environment going to look like when we have less control? Do they have the appropriate equipment? So ideally you would take something like Impact on a like laptop with a mouse. That's probably the best setting for taking it. They're working to develop other like tablet-based measures and things like that, but still making sure they have the appropriate equipment. Communicating recommendations is always a potential issue. It's easy to communicate them, on the phone call or on the telehealth call, but there's always that next level of what's the best way to potentially fax these records in a secure way if they need to go to someone else involved in the care, or do we need academic accommodation letters? So that's always a consideration when you're working through these. Mental health considerations, certainly something that always needs to be taken into account. It is relevant to some of our cases. And you always need to have some type of plan or awareness of what are your options if, there is something like, heaven forbid, a mental health crisis on a call. How are you going to go about navigating that situation? And then the truth is, of investigation and really of delivering services, there's a relatively limited body of research on how do you best deliver concussion related services through telehealth. What effect does it? Sorry about that, guys. Where did I get cut off?
Relatively limited body of research around telehealth and teleconcussion services.
Okay, not too bad. It could have been worse. Yep. So yeah, we just don't have a huge body of research yet, and so there are some studies coming out that really does suggest a lot of these different modalities translate fairly effectively. If you generalize off of concussion specific, there has been a lot more research done on looking at the ability to translate just general neuropsychological testing to a telehealth environment. So I think it's definitely encouraging, but I think it's certainly an area we're going to see develop more as telehealth becomes a better way to really provide access to this type of specialty care that, again, we know is very beneficial early on, but we want to make sure we're continuing to do this in a very effective manner. So again, just to highlight some of that, the assessment and treatment of concussion, it's changed. I think everyone would say at this point it's improved, and it's improved because it's become much more targeted. We figure out what you're dealing with, and then we make specific recommendations around that, and we're much more active in that recovery process. And so not only does that allow us to address specific areas of difficulty, but it allows us to do that in a way that tends to really help athletes, students, patients really stay engaged in a way that doesn't affect some of those mood-related consequences to the same extent that we would see in the past, and gets them to that point of fully recovering, which is what we really expect in most of these cases. And at that point can feel really comfortable getting them back into whatever activity it is that they were looking for. And that's what we had for you guys. So we are happy to open it up to any questions now, or again, Dr. Fader generously gave her contact information there as well. So that's another way you can reach out.
So there are definitely a couple questions. Thank you for that wonderful presentation. It's very clear that, as we know, not only the information is knowledgeable, but just knowing that limited access to healthcare is one of those understood barriers for receiving quality care, especially when working with our rural and underserved communities across the state and in the nation. So we know that there is this increased demand for flexibility in delivering concussion services remotely and in clinic. So one of the questions that has already popped up in the chat is, how do schools access your services and partner with you? And it goes along with the next question that says, if our provider wanted to connect with you via telemedicine, how could they go about receiving and maybe partnering with you guys for service? So do either one of you want to take it? I know we can jump in from a GPT side on how we'll kind of collaborate with you guys, but if you guys want to chime in first.
So I'm going to be honest, Abby, my connection is extremely unstable right now. So I'm probably going to let you kind of take the question portion because I don't want to be cut out again.
Can do, yeah, absolutely. So I'd say, I mean, we can absolutely, I'm gonna lean on you guys a little bit on the logistics from your end. I know I believe we have all the pieces set up from our perspective. So I mean, I think it would just be working through the system to get that scheduled, to get that working. And then I think we could really quite effectively get them on the schedule. We like to leave, next day openings for many of our individuals. We know this is an injury that we like to get in front of and treat quite quickly. And so all of the infrastructure is there. And I think we have a good structure to be able to get those recommendations out through our electronic medical record and other secure platforms as well.
So for our customers that are currently on the call, I know many of you, we kind of see the faces and the name when we see the names associated with the accounts. So just know that this is an opportunity for, as members of our GPT network, to expand your scope and provide those specialty services. So we will be working with the Northside Hospital team, the Orthopedic Institute, and the Sports Medicine team, both of the physicians here, to kind of work with you if you are interested. Reach out to us, send us an email the GPT team or your account manager. We'll also take this list and share it with the Northside team and say, hey, if you guys want any soft introductions, we will introduce you guys so you guys can work together to really understand where your students are, where your patients are, what you're thinking, how it's going to work for you. They can talk to you about their process flow, their intake process, and you guys can work that logistics out together. But we are happy to facilitate that conversation for you guys and make sure you guys are connected accordingly. So again, this is an opportunity for you guys in network already as GPT partners to reach out and have access to additional providers within the network. We know that's an ask constantly of what other specialties do you have and who can really reach out to in the network. Here is a specialty service for you guys available.
Yeah, and that to add on, and that's entirely our goal, is to be able to provide this service and really to be able to provide it widely, because we don't want this just to be for privileged individuals or just people close to us. We want to make that accessible, and we do accept all major insurances, of course, through our hospital system as well.
That was a follow-up question that I got directly, was how is it at no cost? So that answers kind of your question. It was something that they would work with you guys directly on billing and direct billing those patients as needed. Do you guys have any services that provide for maybe those who may be uninsured or underinsured? Like, is there a sliding scale fee or is there a fee for service that you guys offer that maybe you could speak on?
So we do, we're working with pretty much all of the state insurances as well, working to get those processes set up, so can work with that. And where there's also financial assistance programs available through Northside, where it's a pretty straightforward application to be able to get it if someone is uninsured, to be able to look at it from that perspective. And there are really fairly accessible self-pay options as well to be able to make this accessible.
Perfect. Thank you. The other question I got direct, do you require a contractual agreement to start connecting with you for services? Or is being part of the GPT network enough of a contractual agreement to just say you guys will partner in itself? The second?
Yeah, we do not have any contractual requirements for this. Just want to be a service that's available. And I think, like we said, all the logistics have been set up on the back end.
And again, I know the question comes up from a lot of our different school-based health centers. I think at this point, I think no number is too small. I think we would love to at least be able to try this, if I'm speaking correctly. Like, let's give it a try. Tell us what your patient caseload looks like. If you have a couple patients, if you have a couple dozen, either way is great. Let us know. We will coordinate and connect you back with the Northside team. Don't feel just because you might have like one or two patients here or there that this is going to stop you. Like, this is kind of what they're looking for. This is what they specialize in. And as you all know, you guys always start small and then you continuously grow. And I know that's how you get your buy-in within your community and with your schools and with your physician. So again, just reach out. Let us know if you're interested. I'll put your account manager, most of you are schools, so I'll put Jennifer's contact information in the chat. Reach out to her as your account manager or reach out to us directly at GPT. We'll put that in the chat as well, and you guys can coordinate and contact us. All right, any final thoughts or comments? Dr. Fedler, were you about to say something?
Yeah, thank you for reading that. Yeah, and we are very open to just if there's just questions in those soft introductions. We're absolutely available to answer those. Just questions. Yeah, again, how does this work with my specific school or my, pediatrician or primary care practice? How do we work together on this? We're happy to coordinate.
All right, Boyd, want to wrap us up in any final thoughts or comments?
Absolutely. Would just like to thank Dr. Fader and Dr. Cherrick and especially Maria from the Northside team for making this possible. We certainly would not have been able to do this today without her. And we're excited to offer this and to partner and support it. So thank you, everyone.
All right, that concludes today's call. I'm going to put in the chat, if you stay on momentarily, just our contact information. We appreciate your time. Thanks again to our presenters and our lovely team for putting this together. This is also being recorded, so we will have a copy of this recording that you guys can play back and share with any of your contacts. We will also post on our social media for reviewing. So thanks again to everyone, and we appreciate you joining today.
Thank you for the time.
Thank you.
Thank you
Thank
guys.
you.
Chat right now, super slow. There we go. Thank you all. Thank you. Take care. Bye-bye.
Okay. Good.
I think that went well. What'd you think?
Absolutely. Very interesting.